Okay, guys, friends, good evening. Dr. Parveen from Dehradun. We have a very different topic today rather than from a routine vascular surgical procedures. Basically, it's our practice. The day we graduate out of the medical college, we start, treating patients. As a surgeon, we start operating patients. And the one thing that we always do before operating is we take a consent. Now, consent is a very, 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 vast, what do you call a word that incorporates lot of things. What we are concerned about today is in the present scenario with lots of, litigations coming up, judiciary involvement, medical legal aspects, criminal laws coming in. It is imperative for us to be, well versed with the process of taking the consent. What I mean is informed consent or a actual consent that in principle means that we have spoken to our intended patient and we have given him every possible detail that he wanting to accept and know, and so that we can proceed with the treatment protocol or the surgery, whatever we intend to do or whatever the patient decides to go for. So informed consent is just not taking a signature on a piece of paper where some, English language or a local language is written where, you tell the patient, you please sign over here and then we can do surgery for you. No, the days are gone. The days are gone that we can just tell them and the patient can also accept the doctor, okay, I'm ready for surgery, tell me where to sign. No, things are not like that now anymore. So what basically means today is what is the informed consent and how we intend to go about it is basically informed consent by definition means agreement of permission accompanied by full notice about the care, the treatment, the service. That is the subject of the consent. And the patient must be aware of the nature of the risk, nature of surgery, the risk attached to it, where as well as the alternative treatment that is available in case he or she decides not to undergo a surgical procedure. And after receiving this information, the patient should either consent or refuses. Either way, we have to respect the patient's willingness. And in addition to the process of communicating, the clinicians are also concerned today with obtaining the evidence of consent. Whether we have really explained it to this patient about the surgery that he's going to undergo, as well as the associated factors with it, because it serves to document their legal and ethical responsibilities. Unfortunately, the emphasis on obtaining a patient's signature as a documentation of informed consent results in varying effectiveness between the clinician and the patient. So communication issues are the four most frequent root cause of serious adverse events that are reported after all these things. So there are the three conditions for a valid consent that has been, promulgated. First thing is the patient must have the capacity to make a healthcare decision. Now, what does it mean by that? The patient with the capacity to provide consent should have following things. As a clinician, only you can judge that. That they understand that they are sick or they are ill and they need treatment. That's why they have come to us. And they also understand that the treatment options and the journal risk and the benefits of all the things put together. They should also have the capacity to make sense of the information that we presented to them. And they should be able to process it rationally to reach a decision that improves their healthcare. And they should also have the capacity to communicate their wishes. They might have not many things on their mind, they may not be able to, but only if they are able to, then only we can tell them, yes, we can go ahead with this. Second point is that patient receives adequate information, which is very important. At times, we all are in such a hurry or we are so much occupied that we are not even able to provide good information. But then we should have to have a change of our practice a bit, that we should be able to give them adequate information for them in their own language, as per their own cultural settings, so that they're able to process that information and they happen to come to a decision that whether they want this surgery or this treatment or not. The third thing is that patient should consent freely. Patient should not be coerced, or he should not be under duress into accepting the treatment by a physician. Making a strong treatment recommendation is persuasion, not coercion. It is only when put undue stress on the patient that patient comes under duress or is coerced. Or it's also certainly coercive to deceive patients through misinformation or by exaggerating the harm of not following the recommended treatment or the benefits of accepting the recommended treatment. Why this is important? At times, patient does not have enough time to comprehend, to analyze the information and give consent. And if the patient is advised or patient is asked to sign a consent, or when the consent is being taken on the day of surgery, patient feels kind of coerced, as if I don't say yes or no today, my surgery will be postponed by a day or two, or maybe for another week or month, which may happen in a very big sector where there is a long waiting list. And this situation, at the point may be an issue of consent is obtained upon the day of surgery, that patient was coerced into giving yes for the treatment or the surgery that he was to undergo. Now, the important part is, who among us should be taking the consent? Most of the times, where we are working as a team in a bigger setup, it is often obtained by a junior medical staff, or during the pre-assessment clinics, or at times on the day of the surgery. Should not happen. The current guidance states that the person obtaining consent must either be capable of performing the procedure themselves. The person, like let's say the operating surgeon, if not the operating surgeon, the assisting surgeon, should be able to talk to the patient, explain him in his or her language, and he's the one should be, if not possible, to be physically present and discussing it with the patient himself or the patient's relatives or attendants, or a person who has received specialist training in advising patients about the procedure. We might have some people in our departments who are specially trained for this purpose, who know the intricacies of the treatment or the surgery that we are going to perform. They should be people in the front line who should be taking the informed consent from the patient. What is the timing of the consent? Like I just told you, it would be wiser to obtain an informed consent at the time of when we list them in the surgical list. It should not be done on the day of the surgery or just before the surgery or in the pre-anesthetic room. Because when you do it time bound or give a sufficient time to the patient, maybe a day before, maybe 2 days before, whenever you put the patient on the surgical list, that is when you have enough time to explain the risk and benefit of the surgery, and the patient will feel under less pressure to proceed, and hence he will not be acting under duress. Now, third part of this is explanation of the procedure. Again, the importance lies with the treating or the operating surgeon or the surgeon assisting the chief surgeon. We have a responsibility to explain the procedure to the patient or the surrogate of the patient. By surrogate, I mean the person who is responsible for the patient's action during or after the surgery. And it should begin with a brief explanation of the planned surgery, including the anesthesia involved. Though anesthetic part is not prerogative of the surgeon, you should have, or your anesthetist, pre-anesthetic assessment, anesthetist should be able to tell them about the possibilities of the good or bad effects of the giving a specific type of anesthesia. And it's always wise to describe what the patient may expect to experience during surgery, and especially under the local anesthesia, because there the patient is awake. And we certainly should avoid as much as possible the medical terminology. because patients don't, not all of them are, medically inclined or the medically knowledgeable. So we should be able to tell them in their own simple language. We should also tell them the risks as well as the benefits involved with the surgery and any alternative treatments that are available. But the most important of them is we should also tell them what are the risk and benefit of not doing anything. Not only that we have to tell them what we are doing is beneficial or detrimental, but we should also tell them if we don't do such a such thing, what can go wrong or what cannot go wrong and how the disease is going to progress. So at least they are in a better position to comprehend and to decide. We must have explained the potential risk of everything that we are going to do. Now there's a debate arises as to how much to mention, how much to tell about the risk. The list is unending. So one argument is that the patient should know everything. One group of people says the patient should know everything. Not always possible. And the opposing argument is saying that this will only serve to confuse the patient. See, patient is not medically inclined. It all depends. Ultimately, the decision comes to the surgeon. And the advice to the surgeon is he should warn the patient of anything that poses a substantial risk of grave adverse events. The surgeon should also mention significant risks that would affect the decision of a reasonable patient. Doesn't mean that patient is an uneducated one, that you should not be telling him some serious complications. We are still unbound to tell them what serious things can happen or what less serious things can happen. That includes a very well educated patient also. Patient could be medically inclined, and we should be able to tell them, yes, these are the possible risks that are attendant to the specific procedure. So at least they are in a position to decide whether they want to undergo or they don't want to undergo. And it is surgeon is under clear and legal obligation to tell the truth if asked a direct question. That means patient might ask you directly, doctor, can it come again? Can it recur? We should be in a position to tell them honestly, yes or no, whether it can or it cannot, or whatever conditions attached to it, whether this condition has a propensity for recurrence or no recurrence, and what are the reasons for that, so that at least they can decide whether they can adhere to that post-operative compliance or not. As all patients are different, it is our duty to highlight the patients who are unsure. And all of us have seen patients who are always kind of, I don't know whether I should. Some people say this, some people. The basic idea for us is to give them more time, to give them pros and cons of everything that we are doing, and give them time to decide. Do not force them, do not put them on duress that they should be, saying yes or at the extreme no to any given surgical procedure. And information regarding surgery, good information associated with the risk associated with it, it has been shown to have a positive or a neutral effect upon the decision. Patient feels if my doctor is so honest with me, so clear with me about the surgery and its associated risk, they might ask you in percentages also. So we can give them a general percentages that is worldwide acceptable, or we are also liable to give them our own success rates and percentages that help them decide whether they should be getting operated from ourselves or somebody else. Some patient may wish to know little or nothing about the risk. We do get patients. They just tell you, doctor, I trust you. You do whatever you want to. Just tell me what to think. It should not be assumed. At times we have people who are known to us who say yes, but then we should not assume that they don't wish to know. It is our duty to tell them, to explain them. We must presume that all patients wish to be well informed of the benefit and risk. And if the converse is true, one should abide by the patient's wishes and document this to be in the case. Let's say the patient is saying, doctor, I'm still not fine, I'm good with it. You decide whatever is best for me. Then it is our responsibility to make a note of it in the file, in the consent form, that in spite of patient's wishes, I explained him this is the potential benefits and the risk, and I am documenting it in the case, patient doesn't wish to know, but still I have to done it. And this should be written by the operating surgeon himself. Not only the risk, the importance here comes is why the patient has come to us is basically he wants to get rid of his ailment. So we should be able to tell him about the potential benefits of the procedure or the treatment that we are about to carry for him. So it is sensible to remind the patient of the possible potential benefits of the treatment, and the frequency of the success can be balanced against the frequency of the risk. How much is the success rate? What are the success rates of an open surgical procedure or a endovascular procedure or a minimally invasive surgery? So appreciation of this balance underpins the concept of informed consent. So at least now the patient knows what are good things, what are the bad things, what are the high risk and what are the low risk things. At least now he can make a sound judgment and he can give his consent what he actually wants. We, as a treating physician or a clinician, we should also explain the alternative treatments available. There are lots of locally available, lots of religious things available which are not in our scope of explanation. We are not supposed to tell that, but at least as a medical personnel, as a person, as a surgically inclined people, we should tell them what all things, other alternative things are available. Simply like carotid surgery. We have a carotid endarterectomy, we have a carotid stenting. So if we are advocating carotid endarterectomy, we should also tell them that the carotid stenting is also available. Now we leave it to the giving them the pros and cons of each procedure. It is basically now patient's prerogative what he chooses, unless until the patient is confused and he relies more on his surgeon and his skills, that he leaves it to the surgeon. That, sir, with due respect, I request you to do what is best in my given scenario. So that solves a lot of problems. And we should also explain the outcome if the surgery was not performed. It is not only that because we are surgeons, we are going to operate on them. There are a lot of patients that we tend to treat them medically. But at times when we know this particular patient, for example, a claudicant, in certain claudicant surgery is advisable, certain surgeons advise surgery and certain surgeons do not advise surgery. So as a clinician or as a vascular surgeon or an endovascular surgeon, we should be able to tell them this peripheral arterial disease, what is its natural course of the disease, how it is going to affect his life, whether if I operate, how much is going to benefit with the surgery, and if I do not operate, how much is going to benefit with the best medical treatment. So most of the time, the immediate results of the surgery are not evident, but the long-term possibilities, spontaneous resolution or worsening of the patient, we should be able to tell the patient, and this may influence the person's decision whether to undergo that procedure or not. We must use additional media. Most of our friends, most of our systems, most of our colleagues, everybody, I'm sure, we are having audio-visual information and deep text that we are dispersing to our patients about different diseases and the surgical procedures. These are not only useful, they are in fact recommended also. But it is not sufficient to discharge the duty of explaining the respect simply giving of the leaflet. We cannot say that we have given you this leaflet, you have read it, and now my job is done. No, it is just an additional information we have given it to. We are trying to stimulate our patients to ask us questions about what is the good or bad thing that is going to happen to them by doing or not doing a specific procedure. Which is now these are not a replacement for a verbal consent that we are going to undertake very time before the surgery. What are the barriers to understanding? A lack of basic information on the consent form. Why I am getting into all this is the consent forms that are at times they are coming off pages, they are same old thing, this is to be done, this is not done, I gave, patient can die, God knows what more. There is no specific information. There is no specific things that are, patient is looking for. A patient of gallbladder surgery or a patient of bypass surgery or a patient of a coronary angiogram or peripheral angiogram, they should not have a single consent form. So the lack of basic information on the consent form is in the form of the nature of the procedure, the risk, the benefit, the alternative is not mentioned on the consent form. We must do that. And there is ineffective provided patient communication. That means either I do not have time to tell patient everything in detail, or the patient is in a hurry, that patient doesn't have time to listen to all the stuff that I'm going to say because he's not able to comprehend. He said, no, whatever you say, no, that is not an excuse. So these are the barriers to understanding that ultimately relate and come back to us in the form of litigations or anger or physical assault or God knows what not. So we should have a good, effective patient surgeon communication so that these things do not come back to us in a negative way. And there is a lack of consideration of the health literacy of the patients. Like I told you earlier, so not every patient is health conscious. We have to understand what is their literacy level. We have to understand what cultural background the patient comes from which geographical area comes from, what are the practices over in that area. We must be aware of, not that we can be aware of everything, but at least the place we are working in, the surroundings that we are working in, we know our, drainage areas, the patients coming from particular community or particular region. We know what are the, cultural practices over there. We must be somewhat aware of it, and we try to communicate it to them in their own understanding, in their own way. So these are the barriers that, for the understanding of the consent, especially for the patient. And what are the safety actions that we can consider? See, the basic idea for us is to promote a notion of informed consent as a process of effective communication between the provider and the patient, and not just a signature. At times we are in such a hurry, everybody's in such a hurry, you've got a long list going on, everybody's saying this patient out, that patient in, just get a signature and let's go ahead with it. No, it should not happen. They should have a clear written policy on the informed consent. That should include the procedures, the professional role of who is going to operate. Every consent form should have that. And we must have a qualified medical interpreters and grown-up patient substitute decision makers. Patient once under general anesthesia, patient may not be able to, give you consent what further is to be done. We should preempt those things. We should take the consent of those things in advance. And at the same time, like I told you earlier also, the surrogate or the next of the kin of the patient who can give consent for the patient, who the patient authorizes to consent, we should keep in touch with them. We should involve them in this discussion process. And the timing, like I told you, it should be well in advance, not on the day of the surgery or just immediately before the surgery. We should also have a formal training program of our departmental staff, our junior colleagues, our senior colleagues, our nursing staff, whosoever is there, to improve the patient-provider communication. And so that at least if they have any queries, any questions, they can put directly to the surgeon concerned. We should also simplify the consent form. Let's have the language. There are consent forms, just like, policy that you take a policy, you have got 10 and 12 consent forms ineligible in a very tiny, font size, and either you accept it or you reject it. That should not happen. It should be simple, it should be clearly legible, and preferably if possible in the patient's own language that patient can read. We should implement policies and interventions for the patients with limited health literacy. And we should use, let's say patient is visually or hearing impaired, we should have gadgets for specific patients like these, or we can take the help of our colleagues, our ENT colleagues, or our off-cell colleagues. We can take the help of the service providers who are the trainers for these visually and hearing impaired patients. We must make available appropriate communication tools and materials based on patients' cultural and language preferences. At times we tell them in English, then we tell them in English. Canadian may not understand that. So you have to be, aware, or you have to be proficient in the local language also. We should also provide tools to improve shared decision making between patient and the providers. At times we have got the small things that lying on our tables. You have a vessel, you can show them how the plaque builds up, how it can gradually close the artery. They understand it when they are presented exactly with it. We have a CT angiography pre-operative, we have an axial angiography. We must sit with them in that console, show it to them. This is how this is actually the location. This is where the obstruction is. This is how we are going to open the obstruction by giving them those visual aids. How can we improve the process and enhance the safety? We must ensure that the informed consent is actually purely informed, not that it just involves that we have told them, they have understood, and they are signed and it's gone. And we should not understand that patient understand all the medical terms, and we should avoid using medical language. Make use of the appropriate communication materials based on patient's languages. We can overcome language barriers by using health literacy screening tools. We should have a template of the visible charts that depict, okay, this material this is the block, this is how we are going to put it across. At times we do that, most of us do that we draw our angiographic report or draw the vessels, and then we try to show them there is a blockage, and we put in two lenses making that this is we are going to bypass. That is how we do it. We must do it to enhance, to improve the process and build up a trust between the patient and the doctor. So all this patient specific information should be included: name of the specific procedure and the treatment, name of the person who's responsible. If the chief surgeon is going to operate, his name should be put on the consent form. By oblique, the assistant surgeon, in case chief surgeon is not available, or whoever he authorizes, we must have those names on the consent form beforehand. And we must have the description of the procedure, relevant description, associated risks and benefits, and the alternatives that it has been explained to the patient. We must properly execute these documents by having a proper date and timing and signatures, and these forms should be present at the pre-operative screening of the patient before even the patient is breathed into the operation theatre. And we must address the consent for multiple or possible procedures. At times, we simply do one procedure, but on table we realize there is additional thing. We might be able to preempt, we might not be able to preempt. But in any case where we have a reasonable experience, where we can say this could be needed during the surgery or after the surgery, we must address that particular reason in the consent form also, so that if tomorrow we have to do, while operating, we have to do some additional procedure in these patients, we do not have to rush back to the patient, or since the patient is under anesthesia, we don't have to rush back to one of his surrogates or the next of the kin to take additional consent form, which is not required, which can be taken preoperatively. Also, we can also make a consent review a part of the surgical safety checklist. We all know that we have a surgical safety checklist in all our operation theaters, in all our institutes. So list of the procedures as well as the site and the site should be reviewed at the multiple points, from the staff nurse in the ward to the junior resident, to the senior resident, to the consultant, and to the operating surgeon, even before the patient is taken up for anesthesia. Everything should be systematically reviewed and signed and ticked by the staff who is responsible for dealing with the patient. The complete consent documentation should be done well before the process is taken, maybe a week or two prior to surgery, preferably in the outpatient setting when the patient or the surgeon decides when it's going to be put, or if the patient is admitted, when the name is entered onto the list, that time everything should be discussed with the patient. Newer consent is automate the consent process. That is, most of these new systems where you have all the electronic information, basically trying to avoid the paper thing. You have informed consent remains a paper-based process in most of these hospitals, but due to the automation process and the new technology, we tend to have this automatic electronic consent, which eliminates the need for a paper chart to travel to the patient. It is all in the system. Even you have the systems in the operation room. You can check that the patient has consented. Now, these electronic consents also have those tools where they can see the procedure, what procedure is being done. They have an additional videos or pictures put into them so that they understand. And when they click on it, that yes, I consent to these procedures. Or if they have any queries, there's always a box where they can write what are the queries or what are whether they yes, whether they refuse or they accept it. So advanced systems also provide libraries of procedure-specific information, like I told you. Whatever surgery or procedure you're going to do, you already have those systems in your library or in your system of the hospital, where the patient can directly go into there, go through all those process, and then he can consent or reject to the specific procedure. Now, what is the Indian law on consent? I think that is one of the most things that involves all of us, and we are keen to know. The principle of autonomy is enshrined within the Article 21 of the Indian Constitution, which basically deals with the right to life and the personal liberty. Now, expression of personal liberty under Article 21 is of the widest amplitude and covers a wide variety of rights, including the right to live with human dignity and all that goes along with it, and any act which damages, injures, or interferes with the use of any limb or faculty of a person, either permanently or temporarily. I am giving you an exact definition of what it is written in the Indian Constitution, Article 21, in a very concise form. Now, what is the patient's consent in Indian law? It defines Article 21, defines patient's autonomy. What does a patient's autonomy mean? That means the patient has the right to know about his disease, about the disease progression, about the treatment that is being offered to it, about the alternatives that are available, and what are the potential risks as well as the benefits of the treatment that is offered to him. That is patient's autonomy. But in India, the various aspects of the consent are neither well defined nor comprehensively spelled out. It is only based on the Article 21 in the Indian Constitution that every law enforcing agency, every lawyer, every judiciary uses this Article 21 whenever there is some medico legal interference is taking place. Patient's consent in Indian law is a purely procedural act. It has got nothing to do with the science of medicine. But in January 2008, the Supreme Court delivered a landmark judgment virtually redefining the law of consent in India. The Supreme Court of India outrightly rejected the informed consent part of the American system, and they redefined the law of consent in India. But in the words of Supreme Court, the nature and the extent of information to be furnished by a doctor to the patient to secure the consent need not be of the stringent and the high degree mentioned in Canterbury, but should be the extent which is accepted as normal and proper by a body of medical men skilled and experienced in the particular field. It will depend upon the physical and the mental condition of the patient, the nature of the treatment, and the risk and consequences attached to the treatment. That is the definition given by the judge of the Supreme Court in 2008. Basically, what they wanted to tell is, you don't have to go into all the jargons of the medical knowledge. It should be easily communicable to a patient of a normal literacy, and it should also address all the attendant benefits and risks attached to that particular treatment that is being offered. Now, what are the essential principles of a valid consent and the Indian law? The Indian law says a doctor must take the consent of the patient before commencing the treatment or procedure. Like we were discussed earlier, most of the time it is not the operating surgeon or the doctor in charge who is taking the consent. But yes, having the dilution part of this particular statement that I just made is that if you have a team and the team have members are enough experience about the procedure and its attendant benefits and the risk, then it is not an issue. But by the law, the doctor who is about to operate on a patient must take the consent of the patient before commencing the treatment. And consent has to be taken from the patient himself, unless until there are lots of categories where patient himself cannot consent. But wherever possible and whenever possible, the patient himself or herself should be giving the consent by the thumb impression or by the signature or whatever means. And at the same time, that same patient should have the capacity and the competence to consent. If the patient is mentally not of a sound health, then it is taken that patient does not have the capacity and the competence to consent. In that way, their laws are different, the procedure is different. But if the patient has the capacity and competence, then the consent has to be taken from the patient. And it should be free and voluntarily. We must inform in detail the patient about the surgery or the procedure or the treatment that we are offering him, but our consent has to be procedure specific. We cannot just tell the patient that we are going to operate in you without telling him what kind of surgery we are doing, which part we are doing, what are our, steps, or maybe what are the different alternatives that we could be using during the say endovascular surgery. We might have to be converted to open surgery, so we must have to tell them that this particular procedure specific, we must mention that procedure in the consent form, so that tomorrow there is no ambiguity, there is no difference of opinion between the patient and the doctor that this particular thing was never told to me. And consent obtained during the course of surgery is not acceptable. Let us say we are going under spinal anesthesia, patient is conscious. And if you try to tell them, no, no, this is the problem we are encountering, so we are going to go ahead with this particular change in the plans. And patient is, because under spinal anesthesia, patient is under duress. Patient is coerced into giving a consent because he doesn't have any option. So that is not considered a valid consent if the patient is undergoing surgery. And if it is under GA, there is no reason that you can go back to the kin or the surrogate of the patient and take a consent. We must take a consent for blood transfusion. We all know that, I'm sure everybody knows that blood is again, transfusion is a partly comes under the organ donation act. So blood is considered as an organ. So consent for blood transfusion for every transfusion you do. Not that once you have done it and it's done with. You have taken a consent for blood transfusion today, and tomorrow you plan to give another blood transfusion, you have taken new blood transfusion consent again. Also, the consent should be taken for examining or observing a patient for educational purpose. At times, we visit our colleagues' labs or centers for this thing, and the patient is not aware. Tomorrow, if this thing is brought into light, that can attract a lot of penalties for the operating surgeon. So in case you are expecting any visitors, you're trying to teach your students, your senior residents, your other colleagues, you must inform the patient in advance and in writing that this particular person who is so and so qualified will be attending or will be observing this surgical procedure or this procedure, this treatment protocol. It should be mentioned and the consent taken for that also. Blanket consent is not valid at all. And like I said, fresh consent should be taken for a repeat procedure. We have done today angioplasty today. We find something is wrong with the patient tomorrow. We tend to do another, angiography and a procedure. We must take another consent for the next procedure we are planning. Not that we have already explained in the procedure in advance. We have already explained in the complications that we might have to do it again. But if we have to do it again, we have to take a consent again. Not that the first consent was valid. And patient has the right to refuse the treatment. We should not unnecessarily coerce the patient into taking the treatment that we are offering. And unilaterally executed consents are void. That means consent form is completely filled up, everything is fine, patient has put the signature. But if the treating doctor's signatures are not there in the consent form, the consent is considered void. It does not hold in the court of law. And to make it more reliable, it is always good to have witness. Minimum one, preferably two, one from the either side. That is one from the patient side, one from the doctor side. Preferably, if you have to one witness, that should be an independent witness. Preferably from what people recommend is from the ethics committee of the institute or the person who's working. The consent should be properly documented, and patient is also free to withdraw his consent anytime. And consent for illegal procedures is not valid at all. The procedures that have been defined illegal by the government of India, by the court of law, and even if the patient gives consent for that procedure, it is invalid, it is illegal. Now, this is one form that has been designed by the anesthesia anesthetist, published in the Indian Journal of Anesthesia, by taking into consideration and the inputs from the legal experts. Just sharing with you, I can share with the PDF on the group also. Now, what are the controversies? I'm sure the lots of friends who are there listening to me, who are watching me, they have got their own questions. I'm sure we have got hundreds of questions, each of us. But there are common controversies that I'd like to discuss today is, does a consent to surgery encompass a consent to treat postoperative complications? Very common. What is suggested is, during the pre-operative consent process, it is desirable to anticipate plausible postoperative scenarios with patients without frightening them unnecessarily. And it gives us a good learning experience to know their treatment preferences in advance. So a lot of procedure we do, we talk of bleeding, hematoma, we talk of infection, we talk of graft thrombosis, we talk of doing embolectomies again. It is not that once the patient has given the consent for bypass surgery and we have done it in the morning and the evening, you take the patient because graft has got thrombosed, you are taking the patient for embolectomy. It is encompassed in the previous consent. No. It is always better that in the previous consent, we have that there are the possibilities of thrombosis, the possibilities of hematoma, bleeding, infection, all these things are there. You take them well in advance, tell them in advance, take a specific, consent for all these things, then you may not have to take it. But anything you do other than the routine, which is not mentioned, then you have to take a consent for that. Now, whether patients should refuse to operate on patients who will not consent to treatment of expected postoperative complications. Now, at times, patient will learn if there is too much of bleeding, and that can happen. We all know that. But there is no right to, on our part, that we could scare or frighten him out of it. We know we are dealing with it. This is a common occurrence. And if the patient says, no, doctor, if there is a risk to death, then the surgeon has the right to refuse. Yes, why not? If the patient is not ready to accept the expected postoperative complications, which are common scenarios, as a doctor, we can always try to emphasize that it is important with this expected complications, which can be managed amicably in the given circumstances in that given department. So we should emphasize, but we should not coerce them or we should not put them on duress. So surgeons naturally want to avoid responsibility for performing procedures when limits are placed on their likelihood of success. Some patients want 100% results. No, nobody can give 100% results at times. So if patient is saying that he wants 100% results, we are in our within rights to tell them, okay, I'm sorry, I'm not able to give you, won't be able to promise you that I can give you 100% results. So you please, we have the right to refuse. But it is coercive for a surgeon to insist that pre-operative consent represents a blanket consent that I told you that automatically pertains to all post-operative complications, irrespective of the subsequent state of patient's health. At times, post-surgery patient's health may not be in a right or in the right or in the mode that where patient is able to give a good consent. So it is wrong for a surgeon, it is not right for a surgeon to take it as a blanket consent that okay, I've done this procedure, and post-operatively if something happens or something goes wrong, I'm within my rights under the same consent that I can go ahead with the second surgery like we discussed earlier. No, it is not. It has to be discussed in detail before you taking him for further surgery. Otherwise, it has to be taken a fresh consent. Now, while it is impossible and may be harmful to try to discuss all possible serious complications before surgery, it is possible to talk about an individual patient's goals and their importance. And it is almost always helpful to include the patient surrogate in this discussion. What does that mean? At times, patients have a toe problem or a non-healing ulcer, and he's got a pain. Now that limits their capacity. Now, what is his patient's goal? What does he want to achieve? He wants to achieve a healing of ulcer. He wants to get rid of the pain. So we have to take those things into consideration. What are the patient's goals and what is their importance? And by doing the procedure or the treatment that we are offering this patient, how much goals the patient can achieve by our treatment. We should be very crystal clear with the patient in telling them this is what is going to happen, because the immediate results may not be evident. Immediately, patient's pain may come down from the scale of 10 to maybe 7, maybe to 6, maybe 2. But ulcer healing takes time. So he must be aware, she must be aware that ulcer is going to take time. Pain may not go 100% immediately, but it will gradually come down. Patient should be aware of that. All this communication can be time consuming. We all agree. But because it necessarily raises opportunities for questions, counseling, and additional meetings, we should not consider as that one meeting is done and job is done of taking consent. No. Patient may still want to come back to you and ask you further questions and ask you further queries. We are within our rights and we are within our responsibility also towards our patient that we should give them that time and we should be able to answer his queries to his satisfaction. And busy surgeons may not always have the time necessary to conduct detailed discussions. But this discussion can be shared as a team effort, like I told you earlier, using capable assistants who can explore the patient's preferences in various scenarios. This can be very well done in our institutes where you have a bigger team, where the junior staff who knows the patient's background, the patient's cultural beliefs, and they can give those inputs to the treating surgeon in the presence of the patient, and the whole thing can be done in a very simpler and amicable way. Now there is a controversy of a patient of 18 years or more without the capacity to give consent. What to do? And there is a patient who's under 18 years old who's again without the capacity. There are different consent forms that have been designed by the various institutes worldwide that a patient of a legal age who has attained the legal age of 18, most of the countries have 18 legal age of giving consent. So most of these hospital and institutes, including the NHS and the American, not in our country specifically, have designed the various different consent forms how these patients can give consent to the surgery or the treatment that is being offered. Like if a child is unable to comprehend and retain information material to the decision, or is unable to weigh and use this information, the consent must be sought from a parent. Now again, the parent, who's the parent? Either mother or a father. But then again, it has to be in a sound mind to understand, to analyze the knowledge that is being imparted. But if a child has the mental capacity to perform the above two tasks and is able to give informed consent, even in a child who's under the age of 18 years, his or her consent is still considered legal. While a child of under the age of 18 may be able to legally give their consent, should they refuse their consent to a procedure, This can be overridden by someone with parental responsibility for their child. Now, even in the Indian law, this is applicable. A child at times may refuse, though we know that he can understand. It can be overridden by a parental responsibility, whoever is taken for the child. Because that person, the person of more than 18 years, by legal law is considered more mature to comprehend the situation and understand the situation, and he or she can override the child's consent to refuse for the particular treatment. And if a person is able to give consent but physically unable to sign the form, then another person may sign as a witness that consent was given. Now, this witness preferably should be either from the child's kin or surrogate, plus minus a third party or independent party. In court, disputes often arise about what information was given. It may not be enough to say for a doctor that I usually give these potential complications for this procedure. No, the court doesn't believe that. This usual practice will not hold if the court believes the patient more than the doctor. And we all know that it's the present scenario. So therefore, clear documentation of the risk and benefits explained is the doctor's best defense. And as a result, specific consent forms have been designed listing specific information for specific procedures. While this provides standardization, informed consent must still involve a verbal explanation of what is written on the form. The law is dynamic. It will keep on changing. And laws applicable to medicine will also keep on changing in the future. So nothing is solid, sound, and long lasting. A lot of remedial work needs to be done to minimize future litigation. And as many doctors misunderstand their legal obligations and haven't caught up with the change in general thinking. The primary focus of informed consent is an ethical and legal imperative, improve compliance, which has the potential to increase the efficiency of staff also, ensure accurate documentation, enhance the doctor-patient relationship and communication, and overall improve the patient satisfaction. And all of these are exemplary pursuit of any healthcare organization. Perhaps the most scrutinized document during an accreditation or a validation survey are the hospital's informed consent form. To summarize, make sure you are suitably qualified to take informed consent for that particular procedure. Choose the appropriate consent form to use. Aim to gain informed consent before the day of the procedure. Must explain the procedure, its risk and benefits, the alternative treatments, and the risk and benefits of not doing anything. We should avoid the medical terminologies as much as we can, and we should not rush into the things. We must give time for them to understand. And it is not only ethical to impart correct and necessary information to a patient, but it is also important legally. And this communication should be very well documented. Even professional indemnity insurance may not cover for lapses in obtaining a valid consent, considering it to be an intentional assault. To conclude, consent is an opportunity to guide the patient to the right decision for them and also dispel any unrealistic expectations concerning the procedure. Ultimately, it is an opportunity to create a relationship of openness and trust between a doctor-patient, and which may help if operative complications are encountered. And with the high healthcare expectations, a poorer than expected outcome may lead to a surprise and subsequent anger. A good patient education during the consent process is a surgeon's chance to forge a relationship with the patient and make sure that patient's expectations are realistic. Thank you guys. Thank you very much.